It's great to be here, and thanks so much to the Anna Freud Centre for organising the event and for inviting me to be part of it. My job is, as mentioned, Assistant Director of Public Health for Camden in Islington, and in particular, I lead on work with children and young people. In that role, I work with doctors and nurses, social workers and family support workers, teachers, psychologists, police officers and others, thinking about what we can do or how we can do things differently to help people improve their well-being, prevent ill health, and in doing so give everyone the chance to thrive in this amazing corner of the world that is North London. Over the past year, I've been working with colleagues grappling with a wide range of issues: how we prevent youth violence and specifically knife violence, how we more effectively engage with young people and families who are at best ambivalent and at worst alienated or fearful about how public services can help them in their lives. People with severe and multiple disadvantage such as homelessness and drug addiction who often feel failed by services, and many of our young teenage parents with troubled histories of involvement with sexual exploitation. Michael Marmot, doyen of Tackling Health Inequalities, talks about understanding the causes of the causes. And the evidence suggests that the root of many of these challenges that we're grappling with lies experiences of trauma. Oh, not working. Oh, there we go. In the mid-1990s, two researchers working for Kaiser Permanente, a US-based health maintenance organisation, were interested in the differential dropout rate from an adult obesity programme. Eventually, they surveyed over 10,000 of their HMO members, and with that, a new methodology and a kind of lens on human experience in many ways was born. The first ACE study, ACE standing for Adverse Childhood Experiences, showed this strong connection between childhood trauma and later life health outcomes. The ACEs they looked at, you can see there: abuse, neglect, what they called mother treated violently, household substance abuse, household mental illness, parental separation or divorce, and having an incarcerated household member. And the ACE study, that original ACE study over 20 years ago, had a number of striking findings. One was the sheer prevalence of these adverse child experiences. This population in Southern California was not a disadvantaged population by any means, and yet the prevalence rates were high. More than half of respondents reported at least one of these adverse experiences. A quarter reported 2+, more than 10% had 3 or more. The second striking finding was how strong the link was between these adverse experiences in childhood and any major health outcome, physical or mental. Heart disease, strokes, diabetes, poor mental health, plus a much wider list. And the third key finding for me related to the cumulative impact, what we call the dose-response relationship. The greater the dose, the greater the numbers of adverse experiences, the greater response, the higher the likelihood of poor outcomes. In the 20 years since that first ACE study, it's been replicated many times in many places and looking at a range of different outcomes. And ACEs have been shown to be associated with so many of those social concerns that I mentioned before. Here's one study from Spokane in Washington, US, which looked at the relationship between ACEs and educational outcomes and shows again that strong dose-response relationship between key educational outcomes: academic failure, attendance, behaviour. It took until fairly recently for the ACE methodology to find its way across the Atlantic. Mark Bellis and colleagues at Liverpool University, who'd had a long-standing interest in youth violence prevention, conducted a small ACE study in the UK a couple of years ago, and then last year a major ACE study in Wales, and again found similar results. The prevalence of ACEs was similar to previous studies and the impact similar. They had a particular focus in the Welsh study on mental health. And here this shows the strong relationship, that strong dose-response relationship, the relationship between childhood adverse experiences and mental well-being in adulthood. And what it shows is that strong relationship. Like all risk factor research, it shows that these things aren't deterministic, that there are different routes in people's lives and people take different patterns, but how strong that relationship is. So this growing epidemiological evidence base from the ACE studies has come together and coincided with an emerging clinical evidence base, which our other speakers will speak about, and an emerging neuroscience evidence base as well, and together have really brought trauma and the understanding of trauma to bear on our understanding of the trajectories that people's lives take. And I think with that emergence and with that greater understanding, I believe the understanding that trauma is a major public health issue. Jack Shonkoff from the Harvard Center for the Developing Child explains the relationship, those links between adverse childhood experiences and those stressors and the emergence of trauma well, I think. All children, he says, face moments of adversity, and learning how to respond supported by adults is a positive stress that's part of normal child development. At times, children face much greater stressors, much greater adversity, the loss of a loved one, serious injury, the traumatic events that the ACE studies look at. And here, while the trauma itself may be very significant, the impact can be buffered by that presence of a supportive adult. However, when the trauma is strong, frequent, or prolonged, those adverse experiences such as exposure to violence or neglect, and where they typically happen in a context where the ability to trust those who you should be able to rely on lets you down, those stresses can become what Shonkoff calls toxic. Here, the impact is traumatic in both meanings, that it's deeply distressing and that it causes injury. So we don't have an ACE study for Camden or Islington, but we do have a lot of ACEs here. Our children's social care data shows us that. In Islington, there are approximately 43,000 children. So in 2013-14, of those 43,000 children, there were 7,000 contacts to Islington's children's services. That's around 1 in 7 of Islington's children in a given single year. And the size of the circles here represent the issues that led to those initial contacts. The large circles obviously represent the greatest contacts. So what we see is domestic violence being a really huge cause of concern that's leading referrals about children to children's services, and other ACEs very evident there: parental mental health, neglect, physical abuse, criminal behaviour, and others as well. So of those 7,000, that led to 2,800 detailed assessments by social care based on an understanding of the need to do that, around 2,400 different children. That's around 5%, 1 in 20. Here again, the bubbles mean the same thing, but actually we see the ACEs coming even more to life in this chart once the detailed assessments of families has happened. So domestic violence remains a huge issue, but so does parental mental health, and alcohol and substance misuse is very strong. All of the ACEs so prevalent in these analyses, in these assessments that children's services are doing of children's and families' needs. And I find these numbers eye-watering. These are not the Camden and Islingtons of popular imagination, or indeed the daily experience of many, but they're not either tiny sub-pockets of groups of people living in forgotten corners of the borough. These are really significant proportions of our communities living in every part of our boroughs. The scale of need is really great. However, when we see these numbers, I think we can make some assumptions as well. The first is, if we base our understanding of need on prevalence from social care data, we're going to be underestimating prevalence significantly. There's plenty of evidence to show that there's a lot of hidden harm. Secondly, as much as we're concerned when we talk about so much the importance of early intervention, if all of this data tells us that in fact a lot of the interventions that are happening late, because this is what we're seeing in assessments when children are coming through to our services. And the third is that the real recognition and reality that most of the interactions that the children represented in these circles and their parents, most of the interactions they're going to be having are not with our specialist services, but where they're having interactions with services at all, they're with universal services, schools, health services, police, housing services. So what does this mean? What would a recognition of trauma as a public health issue mean for us? Well, firstly, I think it's a reaffirmation of the evidence around the social determinants of health and the role inequality plays in shaping people's lives. The recognition of trauma as an experience, as a mechanism that links childhood adversity to later life poor outcomes, should not be about losing sight of how important inequality is in shaping those life chances. If we want to reduce childhood adversity, the most effective thing we can do is to reduce those adverse childhood events, and the sequelae of those will fall as well. Secondly, would be to directly focus on some of these ACEs, so work, for example, that we do, and trying to do much better on supporting parental mental health at all levels of need, and that kind of work is hugely important. However, given our reality, I think we also need to look at how we support people better who've had these experiences, and indeed make every effort not to exacerbate them. Insights about trauma are increasingly common in our children's social care, and they should play a really key role, both in informing our understanding of children's risks and their needs, but also the experiences their parents have faced and what's likely to make a difference. But if we're going to grapple really effectively with this issue, I think our universal services need to play a role too. Our children's centres, our schools, libraries, police, housing services and others all have an important role to play. There's a burgeoning movement around trauma-sensitive schools and other approaches like that. Trauma-sensitive schools, for example, which are focused on ensuring children have a stable, safe and secure platform in their life, which see child behaviour and look behind it for what's underlying, which can respond sensitively to individuals' needs and access specialist support for them where necessary. I think there's great scope for optimism around our services, that people are really trying to grapple with these challenges and using the insights that are emerging from research to develop services and do things in a different way. One programme I just wanted to mention briefly is a project we have locally called Pause. And I can see one of the practitioners here in the audience. It's really instructive. Women, all adults, many of them well past the age at which some would say you can make a real difference on these issues. Women who've had multiple children taken into care in their lives, who all have pasts rooted in deep, deep trauma, compounded by their experiences with social care, are going on amazing journeys. These aren't miracles. These are slow, hard journeys of change with the benefit of a supportive, trusted adult. But it's showing bit by bit how real difference, even with people who have such deep trauma, how a real difference can be made. So as mentioned already, this is an evolving area. Our understanding of both the nature of the challenge and how to make a difference at all levels of intervention will continue to develop over time. However, I think it's vital that these lenses of adverse childhood experiences and the trauma that they can result in and how it shapes people's lives really shape our thinking going forward. Thanks very much.